Effective ambulatory strategies to decrease hospital census is our episode topic. My guests are Dr. Scott Wolf and Dr. Dustin Fowler, both members of BRG's strategy and ambulatory service team. Dr. Wolf is an osteopathic family physician who has held leadership roles in the pharmaceutical, managed care, and health system administration as CMO, COO, and CEO roles. Dustin Fowler is a PhD prepared consultant that utilizes his business analytics expertise to accelerate performance improvement strategic initiatives that maximize quality while containing cost. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimolewski.
Scott and Dustin, thank you so much for joining me today.
Thanks for having us, Nick. It's a pleasure.
Yeah, absolutely. Thanks, Nick.
We've had in previous episodes various different guests that have talked about the cost challenges that are going on right now in healthcare and the length of stay challenges. And frankly, the increased length of stay from an increased census is really constraining healthcare systems' ability to appropriately function. And Peter Chadwick was on a previous episode where he talked about overall discharge volumes are actually down. So it really is just us not operating as efficient as we can. And one of the appropriate strategies in talking with you guys is that, really to focus on an ambulatory approach as a way to yield and reducing your constraining census that you have in the hospital. Can you talk a little bit more about that?
Just taking a step back, if I may, and I'm usually an optimistic person. I'm usually a half glass full kind of guy. But, when we really think about our current healthcare system, we have to be truthful. We're seeing rising costs increase year over year. We're spending in the United States more than 20% of our GDP on healthcare. We're not seeing the reciprocal outcomes in quality and safety. We're seeing a rising prevalence of chronic illness, tremendous unnecessary and burdensome clinical variation in care. And what's most concerning, and you just alluded to it, Nick, is the overutilization of high intensity resources. And all of that is really leading to tremendous dissatisfaction amongst multiple stakeholders, amongst our patients, and also amongst our providers and nurses. We're seeing an exodus out of our healthcare system of those providers and nurses at great and alarming rates. But now here's the optimistic part of me, and the half glass full part of me is, all of that being said, it's really presents an opportunity for change and for us to make that transformational change to really have an impact and achieving the tenets of the quadruple aim. And that's what I'm excited to talk about today.
Great. Yeah. So let's get into the details. I mean, what are some effective strategies that are out there right now to leverage the system and get those patients that don't need to be in the hospital out of the hospital and receiving care on an ambulatory basis? What does that look like?
Sure. So, and you just alluded to it, Nick. It's really leveraging the systemness, both formal and informal, and the resources to really support the seamless transition of care for those patients along the entire continuum, both on the front end into the emergency department and really avoiding those unnecessary emergency department visits, but also moving those patients through in an appropriate progression to discharge and getting them to the right site of service. And so things that we can talk about are, how do we increase access to our patients in the ambulatory setting? And that's really part of an ambulatory strategy.
Obviously, the first step, if I'm a nurse executive of a hospital or perhaps a CNE over a health system, I want to know, do I really even have a problem to begin with around my ambulatory strategy? What type of data points or elements would you be looking at to really discern, hey, we've got a problem here? Or to your point, from an optimistic perspective, hey, we've got an opportunity here to provide timely care at a lower cost.
It really comes down to four main areas that I think about. One, does the health system or the hospital have the appropriate infrastructure for data to begin with? So, are they truly leveraging the EMR to pull the data out of there and are they looking at it? Second of all, are they taking that data and developing it into truly actionable information and putting it into the hands of the operators, such as the CNA or CNO executives? Information such as dashboards, major KPIs, are they continuously monitoring those and looking at that type of information? Third, are those executives putting that data and information into the hands of the actual floor operators and into the hands of the ambulatory operators as well? And then finally, are they maintaining and going with ongoing accountability and setting up meetings and calls to understand what is going on, understand where they are with their KPIs? To even take it a step further, that when you look at those type of KPIs that we want to look at, things that pop out that I would want to know as a nurse executive or an operator is, from an effective ambulatory strategy, what is my time to my third appointment? How far out am I booking? What's my market capture? So for the population that I serve, how much of the market am I capturing in my different service areas? How many number of new patients do I have coming into my health system or into my ambulatory? And then finally, I think a very important piece that health systems are starting to really track today is how many referrals are being generated and what is my keepage and my leakage percentage? How much of the patients that come in, how much of those am I retaining throughout my ambulatory setting and maintaining that continuum of care and that quality of care throughout the system for those patients?
So I'm looking at those metrics that you just mentioned, and oh my gosh, we've got a problem here. I've got a problem where I don't know, physicians aren't confident in their ambulatory strategy that when I have a patient that comes into the emergency department with a new diagnosis, that if I send them home, which they probably don't meet inpatient criteria, let's just assume that if I send them home, I'm never going to get them connected with the community. And so my gut reaction is let's place them in observation instead. And then that yields to a long length of stay because we can't get them in imaging, we can't get them the other consulting appointments and things of that nature. So how do we reconfigure the system so that during that initial diagnosis, or perhaps we don't even know what's going on, but we know they need a follow-up, we can truly get them connected with the resources that they need after identifying, hey, they really don't need to stay in the hospital. We're just placing them in the hospital as a mechanism to get them to see all of these other specialties.
One of the things that are, I think, are growing in popularity right now and effectiveness is setting up central access centers or patient navigation centers, where it's a one-stop shop where providers and patients can reach in and call. And those access centers have a longitudinal view of access points in their system. So who has open appointments in a primary care office or in a subspecialty office? What are the access points in urgent care centers? Really utilizing the nurse in expanded roles with longitudinal care advisors and robust care management services so that those patients can be reached out to and provide that navigational experience or guidance that they need will help direct them to the most appropriate level of care. Right now, the easy button is to go to the emergency department, as you know. And as you just alluded to, once you're in the emergency department, the next easy button is to admit. And so by opening up these access points and leveraging also different technology, virtual clinics, virtual telemedicine modalities, so that patients can be met where they are. And maybe they don't need to come into the emergency department, but we can set up a virtual session through telemedicine and really understand what their problem is and then appropriately refer them to the right side of service.
We had a guest on, I think in mid-May, that was a system chief operating officer, Leslie Simmons, and she was talking about how all of us by nature are going to follow the path of least resistance when it comes to finding a way to provide care for patients. And in many cases, as you're opening up beds in a hospital, the path of least resistance is to admit them or place them in observation status, which may not necessarily result in appropriate reimbursement. When you're looking at this central scheduling, I'm assuming that there's an appropriate mix that providers or specialties will have around same day, next week appointments? Do those vary by specialty? And what's that secret sauce kind of look like? So that if someone needs to schedule out 6 weeks, they can, but also if I need to get someone in tomorrow, I can do that.
Sure. And that really speaks to leveraging, the entire care team, right? So sometimes a patient doesn't necessarily need to see their physician or a specialty physician where they can be seen by a primary care provider or an advanced practice clinician in that primary care provider's office. You are correct. There are differences in access opportunities depending on the specialty and depending on how many specialists are in a particular area.
Nick, I think you hit the nail on the head there. It is really being able to look at referral volume that we have. Let's take an example like gastroenterology. How many patients in my health system do I currently have? And what is my patient access to that? So are my providers at capacity in terms of being able to see, and are we booking 3 months out? And so taking that type of information, being able to see how far out am I booking? Are my providers truly at capacity? Are they as productive as possible? And then developing a solution from that. So if all those criterias are met, then that informs a decision around, okay, do we need to make a physician recruitment strategy for a GI provider because we have so much access needs for these type of providers. So you really want to take that type of information and continuously develop out recruitment strategies for your providers. And Nick, I think I'll take it even a step further to what your previous guest, Leslie, said, the path of least resistance. It's not only about opening up the access and having it available. We have to allow these clinicians, these providers, an easy solution to get it. And a lot of times, while they're trying to put in a referral, while they're trying to get the patient out of the hospital and into the ambulatory setting, the EMR is typically not optimized to do that, right? And so we have this huge problem where we go to push the patient through and we have to climb Mount Everest to push a button to get the patient out of the hospital and into the ambulatory setting. And so I would take it the step further and say, having the access, having the providers out there is wonderful and great, but we really also have to focus on developing and maximizing and optimizing the EMR to allow those providers to get the patient out the door and into the ambulatory setting. Because right now it's very complicated to get through that discharge process for those patients.
Another element of this conversation is we have to re-educate our patients as well as our providers on how to utilize the system more appropriately. Leverage the technology that's now out there. As I mentioned earlier, there's a host of digital solutions that our patients can access. There's virtual platforms around telehealth and e-consults that we can leverage. There's also now the expanded role of wearables and remote monitoring. And that's a tremendous opportunity to interface with our nursing leaders and our expanded nursing roles to be able to engage and interface with patients while they're at home and having that clinical information communicated in such a way that appropriate decisions can be made. We're now seeing this evolution of hospital at home and really caring for patients outside of the acute care setting and really around hinging on, as I alluded to earlier, the expanded role of nursing in nursing education and care coordination. Because really when it comes down to it's our patients just need that guidance. They need that support. And it's really to re-educate them as well as the providers to care for those patients in a more appropriate setting and not, as you alluded to, hit that easy button and go to the emergency department.
Dustin, you were talking earlier about metrics. One of the metrics that I like to look at when I'm looking at an emergency department system is the bounce back rate. Typically, medical directors in an emergency department are concerned about what is the percentage of patients or actually reviewing maybe even individual cases of my 48 or 72-hour returns where a patient gets discharged initially and they come back and get admitted. And really the question around that is did they miss something during the initial visit where they should have been admitted during the initial visit? But I would almost propose that and have been successful with some clients in looking at the bounce backs a little bit differently. And that is, what is the 72-hour or the 92-hour return rate where during their first visit, they were discharged, and then they come back, and during their second visit, they are discharged. And are there any trends that are there around these patients that are coming back for a discharge visit? Perhaps you have a lot of patients that are getting wound care and they're coming back for their post incision and drainage follow up appointment for packing removal. And so, how do we leverage getting them to an urgent care? Or perhaps, and I've seen this in some areas where you notice a trend where a lot of patients are coming back and they're your ortho patient population. And you're like, why are all these ortho patients coming back? Well, they've got simple fractures. They weren't admitted. They were discharged home. They're trying to get a follow up with an ortho doc. They've run out of pain meds and they can't get in to be seen. And so, using and leveraging those trends as an opportunity to figure out where my access point problems are. What type of pain points have you seen on the inpatient basis as a leverage or measure of, hey, we have a problem here and we need to focus in on this one individual area?
Yeah, Nick, that is a great question. When that patient is discharged, I would take it a step further and say, okay, if we review this on a case by case basis, did this patient truly need to see follow up care with a primary care physician, or did they need to see follow up care with an orthopedic or another type of specialty? Did that referral get made? And you know, did the patient reach out? And I think that's an alarming problem that a lot of healthcare systems face today, is that they put the control of their own care into the patient's hand when it's the responsibility of the providers and the health system to do that. And so by leveraging strategies that Scott alluded to earlier of creating this central access center, puts the responsibility of that access center to say, okay, this patient's being discharged from the ED. They're going to need follow-up care with their primary care. Let's take the initiative. Let's reach out to that patient. Let's get them directly scheduled into that primary care physician's office or that other specialty to reduce those bounce back rates, right? We don't want that patient coming back to the ED. So they go back, or to your example earlier of around wound care. They need help with their wound. Okay, this access center can take that and say, hey, we're going to get you in with our outpatient wound care center and we're going to get you treated for this. This is the appropriate level of care that you need. And to Scott's earlier point, it's all about the education, not only of our providers and our clinicians around what is appropriate for the patient care, which is, again, to the quality of things and that they're the experts there, but it's also to the education of the community and the population that those health systems serve. So how do we educate them on what is available, what is appropriate type of care, when to go to the ED, when to not, when to see your primary care, when to go to an urgent care. Those are all type of initiatives that I think health systems are facing today to educate their population that they serve around what is the appropriate type of care that I need to be receiving.
Another initiative that we're working on that you just alluded to is really the opportunity of having patients leave the hospital with those appointments in hand. Typical discharge instructions ask the patient to go home and make their own appointments. And you know how complicated that can be. And so through some of our initiatives that we're implementing now, we work with the care management team, we work with the nursing team to actually make sure that those patients are leaving the hospital, particularly those with high risk readmission, to your point, bounce back rates, with that appointment in hand. And that greatly reduces the readmission or the return to the emergency department tremendously.
Now, can we take that a step further, though? I mean, what if you're with your primary care doc and you're getting a referral to GI or an endocrinologist? Is it possible that a structure can be set up so that you're leaving that primary care doctor's office with that referral, and not just a referral, but the actual new appointment?
Absolutely. And that's the central access center. So those offices can have direct input either through telephonically or even in ideal states electronically through the system, and have access directly into those specialty practices through open template management, through same day appointments, or through those central access centers where they're skilled at understanding what the clinical need is of the patient and what is the specialist of need that they will then set that patient up with an appointment. And oftentimes it can be done right there in the office, but sometimes that those centers can reach out to the patient even after they leave, but will make sure that they're navigating through the system appropriately by giving them those appointments directly.
A lot of our conversations so far around access have been focused primarily on seeing a provider, whether that be a physician or an advanced practice provider, I'm wondering, does this also play into diagnostic testing? How quickly can I get an X-ray? How quickly can I get a CT? How quickly can I go through a prior authorization process and then get that MRI?
Absolutely. And again, depending on the robustness or the maturity of your central access center, all of that functionality can be embedded in that center so that all of those processes are done seamlessly and efficiently and much more effectively.
So, Scott or Dustin, give me an example of some of the outcomes that you've seen when you've set up a central referral office or when you've helped restructure an existing central referral office for a healthcare system.
We set up these central command centers in previous organizations where we've seen outcomes such as enhanced network integrity, making sure that those patients are remaining within the network of providers within a particular system, which obviously adds to efficiency and communication across providers. We've seen improvement in access to third appointments, which is a measure of how efficient your providers are scheduling. We've seen a reduction in emergency department holds because it avoids that unnecessary visitation to the emergency department by providing them an appointment in a timely fashion to a primary care or subspecialty service. So in that sense, we've seen reductions in length of stay, improvement in achieving your what we call OE ratio, which is a reflection of how long it takes a patient to get through an acute care stay. By having that central access center and that coordination of care, you're able to more efficiently and effectively move your patients along their journey to the most appropriate site of service.
What type of a benefit does that bring to organizations from a dollar perspective? Is this purely clinical or is there a true money opportunity here as well?
There's a huge financial benefit and cost savings to the hospital by getting those patients out. But by employing a true central patient center, central access center, whatever we want to call it, that also allows financial benefit through the system of seeing those patients in the outpatient, in the ambulatory setting by maintaining their keepage rate, right? And increasing that keepage and increasing that continuum of care. So not only would I say in some clients we've seen as little as 2 million up to some clients we've seen up to 8 million in benefit by employing a true central referral office and patient navigation hub just by focusing on the referral. But there's another piece of that that by truly taking that patient from the ED or from the inpatient and getting them out of the hospital and into the ambulatory setting by seeing their primary care, seeing a specialist, we also can measure and monitor what is our readmission rate. Obviously, as that readmission rate comes down, then less and less penalties from your payers and from CMS and that's a huge financial benefit and pickup to the health system as well. And so I think the heart of the conversation is by creating these type of centers and navigations and being able to monitor that, there's huge financial pickup for the system all across the board by getting them out of the hospital, by increasing the access to the ambulatory site and being able to bill for that. And then finally being able to reduce your readmission rate to increase or decrease your penalty rate.
So I think I've taken from our conversation today kind of a 4-point checklist if I'm a CNO. One, how am I leveraging the EMR technology as it relates to ambulatory care strategies? Two, how do I shift the easy button from admit or observation to scheduling for outpatients and follow-up appointments and making things easy for the providers? Three, do I have the right mix and the right volume of specialty services based upon my demand and my need? And four, which kind of goes back to two and three, what does the central scheduling process look like? And is it easy both for the provider and then also ultimately for the patient? Is that a good sum up as a checklist for CNOs?
Absolutely.
Great. Any closing thoughts?
COVID really shined a light on some of the blemishes that we have in our healthcare system. And I think it really creates an opportunity for leadership, healthcare leaders, to really make that transformational change so that we can achieve the outcomes of that quadruple aim by providing better care, better outcomes at a better cost, and ultimately a better experience for our patients and our providers across the board.
Scott and Dustin, thank you so much for taking the time today to discuss all things ambulatory care strategies.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.